thank you for this opportunity, Dr. Krishnan and the team here. I'm going to be talking to you guys about the use of IVUS in endovascular interventions. Oh, sorry, going to the last slide. I have no relevant disclosures. Just an overview of the use of IVUS among endovascular interventions. This one's from a database of Medicare beneficiaries between 2016 and 2019, reassuring trends that, in general, the use of IVUS is increasing, more so in the ASC OBL setting, and this kind of stratifies it across the usage across specialties. In general, this kind of large database of almost 500,000 patients, there was about 11% use in IVUS, but when IVUS was used, there was a significant reduction in major adverse limb events, in acute limb ischemia, and major amputations through a follow-up of almost 500 days. Why use IVUS? Because we have a wealth of information from coronary data that IVUS has been associated with lower cardiovascular death, lower rates of MI, lower target lesion revascularization, and stent thrombosis. IVUS usage during cases can help us gauge, plan our procedure. It can help during the case, and also in terms of mechanisms of stent failures, can give us a lot of information when used. In terms of pre-planning, it can help us kind of figure out our landing zones, our distal healthy reference, proximal reference, our area of stenosis, and also for plaque morphology, whether it's more kind of fibrous plaque versus fibrofatty, or if there's any kind of thrombotic component. Obviously, the amount of calcium and the burden of calcium kind of also dictates what kind of techniques or additional plaque modification tools you're going to use for your interventions, and also to kind of visualize any kind of complications such as intramural hematomas, as shown here in F. IVUS kind of supersedes angiography in identification of not just your lesion, but also your stent apposition, and also dissections and things like that as well. This is a case that we published from Sinai, where we kind of showed the use of IVUS during a case. Here you see our guide wire position within the lumen versus in B and C, where we kind of used a subintimal crossing technique, and you kind of see that your guide wire is subintimal and not true luminal. And here it's also useful to gauge our treatment modality. Here, this was our original lesion post-atherectomy. You have some amount of luminal gain, and then after balloon expansion, it kind of also helps us gauge our efficacy of our intervention as well. Post-intervention, it kind of helps us figure out any kind of complications. In this picture, you kind of see a small dissection, malapposition of the stent in this case, which might need more post-dilation. And this here shows you an image of a mechanism of stent failure or restenosis, in which case there is a lot of neointimal hyperplasia in this case. Just to kind of go over, this was a case we did during fellowship of a popliteal aneurysm, a distal SFA, where IVUS came in very helpful. I'll just play the angio so you can see it. So in this case, we were able to use IVUS to kind of not just identify our healthy proximal and distal landing zones, but also the evidence of a lot of thrombotic burden in this aneurysm kind of helped us use a Viabond stent, a covered stent, to really exclude any thrombus, and this was our post-intervention angio. So the use of IVUS in this case was not just useful for identifying our lesion and for our length of the stent and size, but also, like I said, it kind of helped us also with the decision about what kind of stent we were going to use in that case. I'm just going to go through some data with IVUS use in iliac, femoral popliteal, and CLTI interventions. This data is a little bit outdated, a single center retrospective study that looked at iliac interventions and compared the use of IVUS and angiography versus angiography alone, and kind of looked at 3- and 6-year primary patency rates, as you can see with the use of IVUS, very reassuring, even up to 6 years, versus statistically significant improvement in patency rates here. And there were no secondary procedures in the IVUS group versus a 20% rate of reinterventions when IVUS was not used. This was just, there's no comparison group, followed iliac interventions when IVUS was used, and reassuring, again, primary, secondary patency rates at even up to 15 years with the use of IVUS, and this was across all task categories. In femoral popliteal arteries as well, we have some data. This one's, again, a randomized controlled trials of 150 patients, randomized to angiography versus IVUS guided interventions. The primary outcome was freedom from restenosis. And in general, again, a statistically significant improvement when IVUS was used, even in the femoral popliteal space, although there was no difference in clinical outcomes like death or amputations or TLR, but IVUS was associated with larger reference vessel diameters and longer lesions as well compared to the angiography alone arm. This was a more recent trial that was published in the European Heart, looked at symptomatic claudicants with femoral popliteal disease, actually Rutherford 2 to 5. This data came primarily from Korea, and kind of compared IVUS guided interventions versus angiography alone. And as you can see, up to a follow-up of 1 year, in the primary patency rates and freedom from target lesion revascularization significantly different and better with IVUS use. And IVUS use was associated with a larger post-procedure MLD compared to angiography alone. We also have some data with, in regards to the CLTI subgroup. This was a study that looked at 216 patients with CLTI undergoing primarily balloon angioplasty. 88 of them were IVUS guided versus 240 angio-guided interventions. And kind of following the theme of the other studies, significantly larger balloon sizes in the IVUS guided group. There was also clinical improvement in skin perfusion pressures and better wound healing within the IVUS arm as compared to the angiography alone. And again, coming up with a couple more retrospective studies, smaller subgroups, 150 patients, kind of the same theme in Rutherford 4 and 5. Again, IVUS-guided interventions are associated with better wound healing and time to wound healing as well, and lower number of reinterventions. This was a larger database from the Japanese inpatient, all incomers of endovascular interventions. Their primary outcome was minor and major amputations, but they were also looking at the need for bypass surgery and amputations. And again, the IVUS-guided arm fared significantly better, even in this population. And this is also a growing niche in venous interventions and deep venous obstruction, where IVUS does help identify these lesions a lot better. A lot of this data comes from the video trial, which was 100 patients followed over 14 months, where IVUS detected lesions that weren't apparent on venography in about 26%. And when these lesions were identified, the degree of stenosis was much higher with IVUS, and there were more lesions identified. No sort of clinical outcomes in this trial, but IVUS kind of changed the course of treatment plan in more than half of patients, which was also impressive. In summary, we should be using IVUS during endovascular interventions to improve lesion assessment and vessel sizing, to enhance our stent optimizations to result in higher procedural success and lower restenosis, also to better detect calcium and plaque morphology, and for the clinical outcomes of lower amputation rates in CLTI. Thank you.